Thank you very much, Francesca, for these very kind words. And I was invited to summarize my work and life. And in just one sentence, I thought that might be, do what we know. When I visit the ESHG conferences, I hear a lot about new knowledge, new genes, new variants in genes, new pathways, etc. But then in my group, people always ask, so what does that mean to the patient? Can we now improve healthcare? Will they live longer, healthier, happier? Can they indeed choose some tests to do or not to do? Is the information appropriate? So do we really do what we know? And indeed, I have some, interests, not really commercial conflicts of interest, but definitely interests, as already mentioned by Francesca, which also means that if I summarize my life, you will think, but that wasn't just her work, it was also the work of the PPPC, of the Netherlands Program Committee on Neonatal Hilpric Screening, of the editorial board of the Journal of Community Genetics. So indeed, much of my work is not individual work, but it's rather a summary of what I did with many colleagues together. So I'm also very grateful to those colleagues. And then if I stand here today because I received the ELPAG award, I want to thank ELPAG and Scientific Program Committee and PPPC and ESHG. And I remember that the first time I visited ESHG was already in 1985 in Budapest. So it is a family that I know quite long now. And it really feels like friends and family indeed that I am meeting here since decades. So it's really an honor to come to these meetings. On the left on the picture you see the PPPC, the Public and Professional Policy Committee, which meets at ESHG meetings, but also in between. And at this occasion, we were in the Netherlands in a very nice old village, although this is kind of looking old, but in fact quite new. But when producing recommendations, we very often had several meetings in a year. And on the right, you can see me on the ESHG some years ago with one of the previous awardees, Heather Skirton. I'm very proud now to be on a list with A. Tibben and Heather Skirton and Chris Patch and also Jerry Evers-Kieboom. And you see here also that at the ESHG we were always active because we always received these ribbons for workshop organizer or for a member of a committee or whatever. So we didn't just have a name tag, but we also had some ribbons to show that we were very active. And it was always a pleasure, as you can see, because we are laughing. But when you ask me to speak about my life, it goes back a little bit longer, of course. So here on the left, you see my mother, I think in 1955, or approximately 1955, working as a nurse in a pediatric pavilion, as they called it then, in a hospital. And when she married, of course, she couldn't keep working. At that time, in 1957, you stopped working when you married. But after she had 7 children, she started working again. So this is how I saw my family in 1982, when they were 25 years married, my parents. So my mother had gone back to work in midwifery care. In the Netherlands, we have a lot of home deliveries, and she was assisting at those deliveries and taking care of the very young children. And she also took care, of course, of her own 7 children. But if you wonder where my interest in medicine comes from, it is now clear that I have inherited that from my mother. And my father was building bridges, so you have to do a lot of calculations if you want to know what is a good bridge and what is a good waterwork, if you like. And always, he was also keeping pigeons and being interested very much in the population genetics of pigeons. So if I like calculation, you now understand that I inherited that side from my father. So I'm very grateful for the Cornell family to give me these 2 interests of building bridges in healthcare, of doing some calculations of complicated stuff, also in epidemiology indeed. And in a way, I am building on their interests as well. I think all of us feel like we stand on the shoulders of giants, and some of these people were already mentioned in the laudatio. So Leo ten Kate indeed was my mentor, promoter of my PhD thesis in Groningen. He set up the field of community genetics, at least for the Netherlands, and also journals, so also at the European level, and raised the interest in the European Society of Human Genetics. But also Ségolène May I see as one of my mentors. So initially she was working in a registration of birth defects in Rhône-Alpes in France. After that, indeed, she was working for the PPPC, and also she set up Orphanet, and I will come back to Orphanet in a few slides. And then I also put Barta Noppers, who does a lot of legal and policy work in Canada. And one of the reasons I put her is that she pointed me to the Declaration of Human Rights, the Universal Declaration already from 1948, which is stating that each individual in the world has the right to share in scientific advancements and its benefits. So if we do science, it is not just for ourselves because we like it or because we want to publish in very interesting papers, but also every individual in the world should profit from that knowledge and also freely engage in responsible scientific inquiry. So the element of informed decision-making, informed consent, responsible implementation is already also in this definition. In fact, when I found out that this is in the human rights, I was already for quite a while trying to share all the knowledge that we have with other people. But, well, it was clear that it wasn't just my hobby, but it was really a universal human right. So in the rest of my talk, I'll take out a few of these things I did in the past and speak a bit more about that. But first I need a bit of water. So as I said, I started working in the EuroCat registration of congenital anomalies in Groningen in the Department of Human Genetics. But before that, I was trained as a physician, not as a clinical geneticist. That didn't exist in 1984. And also my interest was mainly in the research aspect, so I trained as an epidemiologist in those first years I was working there. So I was recognized as an epidemiologist in 94. And I'll come back to the phase I worked for EuroCat later. I kept working in human genetics, but then I moved to Amsterdam, so still not a clinical geneticist, but working, for instance, on initiating Orphanet, on education, on translation of all kinds of scientific insights in screening programs, and on heritable gene editing. That's not yet doing what we know, but first still exploring what we need to know or understand better. So the start of my career at the Groningen, Northern Netherlands EuroCat registration of congenital anomalies was basically also a big team effort with many physicians who work in those 3 northern provinces who notified children to this registration, gave details of their birth defect, but also the history of the pregnancy and potential risk factors. But they often said, this is the first time I have a child in my practice with this rare disease, so I don't know anything about this syndrome. So I also traveled to many of those local groups of physicians to tell them what I knew about congenital anomalies, went to hospitals to give presentations, etc. So to share again the knowledge that we had. And often I sent information leaflets if, for instance, a GP notified a child with Pierre-Robin syndrome, and he said, what is Pierre-Robin syndrome? I said, this is information for you, a leaflet, and also I often send information for the parents. Of course, upon request, because also some of the people that notified were experts. But that also led to linking up parents with patient organizations, to sharing the information that was in those paper leaflets. It was still a bit before the internet, so people looked for that information and couldn't easily find it. But because we had that central registration, we also had a central point for sharing information. And then while I was defending my PhD thesis around that time, the news came that folic acid prevents against neural tube defects, and basically everybody who wants to get pregnant should try to take a little bit more folic acid. And then the food center in the Netherlands and the patient organizations asked me to be their scientific expert. They knew everything about making nice advertisements, going to patients and giving them information, but I knew about folic acid. So that was a very interesting collaboration. For instance, patient organizations also going to the European Parliament. So one of my most interesting visits to official governmental organizations was with spina bifida patients in their wheelchairs, taking their assistance dogs with them, and we could go through all kinds of gates where nobody else was allowed, but still it was quite impressive because they knew why this is important. And then in that period, the uptake in the Netherlands of preconceptional folic acid was studied by one of my PhD students, and it increased, and at the same time also the prevalence of neural tube defect decreased. But there was a campaign around 95, and after that there were not that many investments to share that news further. So I think it's still close to 50% that are taking folic acid in time. But anyway, this is a very important way of primary prevention of a very serious birth defect. As already mentioned by Francesca, I then wrote a PhD thesis on registration and prevention of congenital anomalies, already thinking about the safety of children and trying to, help them develop as healthy as possible as far as primary prevention is concerned. And we had a research group with many ladies here, and one of them is even present at this conference, laughing very much now. But what was interesting is that here we are standing at the steps of the primary care physicians, so we were already adjacent to the primary care physicians. We're not patients of their group practice, but we are their neighbors. But already at that time, we sometimes had a chat over coffee to try and share our insights. And then at the time I supervised two PhD theses, one on folic acid, and already the subtitle is From Science to Practice, which indeed nicely illustrates the longer line of all my work, and of course also looking for etiological factors. And then I moved to Amsterdam around 2001 and was appointed as a professor of community genetics in 2002. And here Leo ten Kate comes back, the name we mentioned already a few times. He organized also a group discussing what exactly is community genetics, what's the definition, and again it is the application of all kind of genetics and genomics knowledge. It is an art and science, first of all an art, because you have to take into account what is needed in the population, what is needed for patients, what is needed for colleague professionals. And what was quite important is the ethical aspects. He felt that applying something as a public health intervention for everybody might often not be suitable. Very often these are very sensitive topics, so you need to think about the benefit of the individuals in the populations and take care that all the applications are indeed appropriate for the patient you're thinking about. So it might be in the benefit of the individual patient, and then if you add up all the individual patients, it might also be in the interest of the population and decrease, for instance, the prevalence of disease. But the goal, first of all, has to be to serve individuals. And in the Amsterdam period, there were several PhDs again defended, one of which even also carries the title Translating Genetics into Healthcare Practice, and many others indeed also translating some knowledge into healthcare practice. Here's one on training in genetics and genomics that I'll come back to, training for primary healthcare workers. So I did a lot of work in education, but always we try to first ask to the target audience, what do you need? And this was an oncogenetics training that we developed for primary care physicians. So I'll say a bit more of that later. But first, going back to the beginnings in Amsterdam, I was still linked with Ségolène Aimé, and she was starting up Orphanet as a European network that is sharing information and basically building that up as an encyclopedia, not a typical book, but rather an online encyclopedia that could be modified very easily and also could be translated into many different languages. So in the beginning there was something in English and French, or maybe French and English, and then I also helped to set up Dutch part, and because Flemish is very close to Dutch, and because the funding at some moments was much higher from Belgium, much of the texts that are in Dutch or Flemish are also supported by Flemish colleagues. So if you want to know what a certain rare condition is, you can look it up in Orphanet. But if you want to know where to go if you need a doctor, an expert, you can also look at the centers of expertise and the European reference networks, which can be easily found on the Orphanet website. So for patients, they can find experts close to them. But if something is extremely rare, then sometimes it may not be easy for you to find another patient in your country. So if you want to find the knowledge outside of the Netherlands, Orphanet also gives the possibility to find experts somewhere else. Sometimes that experts are just needed for surgery, and then after that you can, have follow-up care in your own country. Sometimes you need a patient organization to share your experiences with families with the same condition. And if that's not found in your country, it may also be quite helpful to have a global network. Many people in the Netherlands speak pretty well English, so if you are connected with people in other countries, that may be quite functional to, have contacts with them. And then, as I said, I did a lot of work on teaching. And if you ask people what they think is important, and you start thinking, if I want to give oncogenetics training, I would first of all, for primary care physicians, maybe have some thoughts now. So in the beginning, we thought the counseling is pretty difficult. This is all about risks, and this is all about disease that may lead to death. And we said to the primary care physicians, do you want us to help you counsel this? And they said, no, we're counseling all day. We speak about risks, and we speak about dying or not dying, and how you want to fill that last few weeks, months, years until you die. So counseling is our business. We speak about risks all the time. So don't explain us that part, but tell us what is autosomal dominant and autosomal recessive, because we don't remember the difference exactly. Tell us how to interpret pedigree. What is a first and especially a second degree relative? So if there is a criterion for referring people to second-degree relatives with breast cancer under the age of whatever, then is a child of a brother, is that a second-degree relative? Or should I first go back to the grandmother and then back to the... anyway, they often said to us, we don't understand your criteria of what is a first or a second-degree relative, so help us draw a pedigree, interpret criteria for reference, for referring the patients. And based on that, we developed face-to-face training and also an online training and a website called Primary Care Genetics, or in Dutch, Huisarts en Genetica. We also did that later with the GenEquip team, several of which are also present in this conference. So much of the learning of that, asking first of all to our colleagues what they need, is in a way still findable on the internet and even on the ESHG website. Also in other aspects, I did a lot on implementing what we know. I'll not go into the details of that, but for instance, in the neonatal screening and in the prenatal screening, unfortunately in my team we have a lot of other people now working also on prenatal and preconceptional screening. So on this conference you heard, for instance, Liedewij Helleman talk about screening also. And if you want to share your knowledge with others, it may be quite helpful to have journals that really aim to share knowledge with others. So I'm indeed the editor-in-chief of Journal of Community Genetics, which is trying to also focus on low and middle income countries, trying to focus on non-genetic experts, and indeed share the knowledge about applying genetics in other populations. And also I'm involved in the Dutch medical journal as a section editor. So if they want to write something about gene therapies or about referring for oncogenetic training or whatever, they also ask my advice. So that's a nice way to share knowledge. One of the highlights of one of those very big collaborative efforts is that as of last 1st June, very recent, we have now a neonatal screening for 26 conditions, and the one added lately was SMA. So we have treatments that are now available in the Netherlands and paid for, reimbursed, but they are most effective if you recognize the condition very early. So the first child that will be born after the 1st of June with SMA probably will have a very early treatment and hopefully not so many severe health impact. Much of the work I did was also shared with patients and or patient organizations, and as I mentioned, in the context of professionals, also for patients, their needs may be quite different from what we expect. Sometimes we think it must be a very hard message that we have for them. For instance, you are a carrier of, let's say, a cardiogenetic variant. And then they say, I always had expected that I was a carrier of that cardiogenetic variant. So yeah, that's not really a very difficult message for me. You may remember that Tibben 5 years ago or so, he spoke about Huntington's, and the message that they were not a carrier of Huntington's often was much more of change for people, because they had prepared their life as if they were Huntington's patients in the future, and all of a sudden the news that they were not a carrier was more difficult to cope with. So also that is of course something we might not have expected. And also sometimes things are much more important than as a healthcare professional you would expect. For instance, the diagnosis of a rare disease. As long as your child has a syndrome without a name, if you go to your, support organizations and you say, I need a wheelchair for my child with a syndrome without a name, they'll say, why is that needed? We don't know what he has. He's not on the list of my conditions. And as soon as you say, but my child has got a diagnosis, many of those doors will open, and suddenly you're not a mother who has a problem with coping with her child and with raising the child in a proper way, but suddenly it is really a recognized medical problem. So just giving a diagnosis, even if there is no treatment, is much more important for patients than we always thought. And I was quite surprised to see that in my contacts with patients and patient organizations, when I tried to speak about them about germline gene editing some years ago, I heard several times, if you could modify this at the beginning of life, that would be quite interesting. In my family, something has been running for generations, and I would appreciate it very much if you could just take it out at the very beginning. And if you had asked me 10 years ago, do you think there is ever a place in healthcare for germline gene editing, I might have said, no, I mean, why is that urgent? But because several patients and patient organizations told me this is important for them, I still felt we need to work a bit more on, as we call it now, heritable gene modification. So already some years ago, we developed PPPC recommendations recognized by ESHG and by ESHRE. And in one sentence, it says the door should be opened. That's a short summary. If you want to know more, Guido de Wet and Wibo Dondorp are in the room. They can tell you much more about it. That opening of the door might imply, for instance, preclinical studies first, but also a lot of discussion. So in one picture, let's open the door and at least start thinking about it and, well, solving some of the very first questions like how to do it in a preclinical setting. But then also many documents mention that dialogue is needed because we need to know what publics think about germline gene editing and why legislations don't allow it. So in the Netherlands, our Ministry of Health indeed gave funding for the DNA dialogue, where many audiences were involved, not the usual suspects, not the experts, but school children, people from neighborhoods with many migrants, so many audiences beyond experts. And my own role in that DNA dialogue was mainly advisory, but also I did some church cafes where I went to speak with people of our age probably, and also there talked with them about the underlying values of why you might want to modify genes or not. Anyway, that trying to understand the values is also something that has been stressed by WHO quite recently, and in the legislation there is some, well, words, some things that we may want to understand better, like genetic identity. What does that term mean, in fact? First, again, to the DNA dialogue. As I said, this was just an advisory role for me, but you can see that not using words, but using smileys or faces that are a bit surprised can help you to see what an audience thinks, and also some audiences that you might never have asked about their scientific opinion, but still children were also pretty happy to speak about this. So coming back to the legislation, there's many legislations that are relevant, but I'll just speak about the clinical trials regulation that was approved in the European Parliament already in 2014. You may know that a regulation is a binding legislative act, so it is immediately applicable and enforceable in all European countries. You can't say we're doing things a bit different from the regulation, but you just have to stick to it. And one of the elements in the clinical trials regulation is that it prohibits clinical trials that result in modification to the subject's germline genetic identity. So here comes an interesting term. Many people will say, don't start with germline genetic modification or heritable genome modification because it might be not so safe, not so effective. But this sounds like a principled objection. Never change the genetic identity of the next generation. And in that clinical trials regulation, we could not find a definition of genetic identity. So with a group of people, including also Floor Goedkoop, a young medical student, and ethicists from Amsterdam, we studied the literature and tried to do a scoping review of the concept of genetic identity. And basically what she showed is that there's many diverse meanings. So it's not clear what could be the relevant context of genetic identity for this legislation. Anyway, further reflection also on the legal aspects is needed, but I'll just discuss a few that might be very relevant in this context. One way in which genetic identity was used was in relation with ancestry. Who are your parents? Who are your grandparents? Where do you come from? What is your people, if you like? The establishment of legal parentage. So if you would not be belonging to that ancestry anymore, to your parents anymore, that might make you a different person. And in another way, it was also used as genetic relatedness and similarity in a biological way, when speaking about human tissue or animal tissue or liver tissue or tumor tissue. So also the sharing of certain biological characteristics appears to be quite relevant. But then again, if you would have a child with many genes the same as their parents and one broken gene, and you would correct that broken gene, in healthcare, if a child breaks a leg and we help the child to fix that leg, everybody says that's a good thing. Why wouldn't fixing one gene with a variant that is pathogenic, why wouldn't that allow the child to still remain with the same parentage and feel linked to the family? Why would it modify the genetic uniqueness of that child? So we don't understand completely, I think, this kind of fundamental opposition against gene editing, and we have to work on that a bit more. Again, on a broader level, on a wider level, I worked a lot on doing what we know, and I would also encourage you to think about how you can do that, to share the knowledge with colleagues in other medical specialties, to share your knowledge with patients and healthy people, citizens, to listen quite well to their needs, because you can only teach them something if, well, you help them in the things that they really don't understand, to listen to the needs of patients and citizens, and to work on responsible implementation. That might also be as a paper that you submit to the Journal of Community Genetics. And of course, much of what I have done was also with my colleagues from the Amsterdam Research Group, Community Genetics and Public Health Genomics. Here you still see the editorial board meeting of the Journal of Community Genetics of a few years ago. Yesterday we had a hybrid meeting where still Kelly and Angus and Domenico were also present, but since it was a hybrid meeting, it was a bit difficult to make a picture. But some years ago, you can see that we had very nice meetings with the editorial board. So if you ever feel like this might be a function for you, don't expect these nice dinners anymore, because hybrid dinners are a bit more difficult. But anyway, it's a very important field. And then this is the colleagues in Groningen at 2 occasions some time ago. But we haven't finished yet in Amsterdam. We are quite soon now moving to the location AMC, so Amsterdam University Medical Center is merging over a couple of years. The Department of Human Genetics is already one department since several years, but now our group is also moving to the place where many of the obstetrics and pediatricians and so are moving. Also, we still have some public engagement projects, and Sam Riedijk got a big grant to work on heritable genome editing, and again I am supporting this. She is mainly doing the work, but I give some advice. And based on that work, also 2 people are preparing a PhD thesis. Diewertje, who's here in the audience, and Wendy Geuvering, who's at home, hopefully also listening to us. And Susanne, who's also in the audience, will be preparing a PhD at the interface with the Public Health Institute of the Netherlands. So we're not finished with doing what we know, but we'll work on for several more years. And of course, you asked me to speak about work and life. So I like also to look at the beautiful skies that we have in the Netherlands and walk with my family. And I'm also very grateful for Berend, Jos and Gilke and Mirjam to walk with me on those beautiful paths. And I'm very grateful that they support my work as well. Thank you very much.
So I'm honored to bestow you, in the name of the European Society of Genetics, of the ELPAG Award 2022. Thank you for all your work and your help, Martina.